that has to do with basically any type of cells that are involved in bleeding control, right? So you can read through this. This is A and P here. The one condition that you need to know under the hemostasis disorders is hemophilia. Okay? This is predominantly what we see in children related to bleeding disorders. Okay? So hemophilia, but specifically factor VIII deficiency. Hemophilia, but specifically factor VIII deficiency. Okay? If there is some problem with clotting in a child, or an adult for that matter, what do we see in that child? Bruising, easily bruised. Okay, so I mean, walk by and hit a table or a chair or a doorknob or something, and it's not just a pinpoint bruise, it's like a large area of tissue. So blue, black, green, purple color, discoloration. So bruising very easily. What else? Bleeding that doesn't stop very quickly. Okay, what else? What is it? But how do you know that? What kind of symptoms do you see in the patient? Epistaxis, nosebleed, easily. Okay? And a lot of times the parents and the people around them are more panicked than the child, right? Because once they learn, they have hemophilia and they learn they kind of know what to do. So everybody else that's panicked around them. Okay, I don't know if you see this in a game or things like that where you have kids school and their nose starts to bleed. What do you do? What's the nursing care, or what do we tell parents about nosebleed? How do we take care of that?
Put pressure and don't tilt your head.
Gently press the bridge of the nose and have the child bend forward. Before, they would tell them to do this. What is the problem with that? Remember, there's bleeding, there could be clots, and they can possibly aspirate. And so now we tell them to bend forward. Because a lot of times you'll see kids, they just do this. Perfect line. Put pressure on the bridge of the nose, have them bend forward. Breathe as normally as possible. You don't want parents and others to panic around them because what you want them to do is calm down. Okay? So stay as calm for the child as possible. We just tell them to put pressure and bend forward. So we do see a lot of nosebleeds in these patients. Bleeding that does not stop. Excessive bruising. Okay? So prolonged bleeding, excessive bruising. Hemarthrosis, that's basically bleeding in the joints. They do a little bit of activity and they end up with a lot of bleeding and swelling in the joints. They're not really doing a lot. Okay? And so this is where we do all of the clotting studies on these patients to see what's going on. In patients with hemophilia, the biggest thing is they're almost coming in, as the levels start to drop, they come in for factor VIII infusion, IV infusion of factor VIII. Okay? So anytime blood or blood products are given, the protocol is going to be the same. We'll talk about that towards the end with transfusion. Okay? You've got to make sure, of course, the order is there. You have followed everything, the protocol on that factor VIII concentrate that you're going to give. Make sure it's the right patient, the labeling, all of those things. Okay? Sometimes steroids are also given. Why steroids? Talk about a little bit about steroids last week. What do steroids do overall?
Reduce inflammation.
It's an anti-inflammatory, right? Anti-inflammatory, so it's overall decrease inflammation, but it's not a first-line drug. Corticosteroids take some time. Steroids take some time to take effect in the body. Okay? So it's not a first-line drug. So the biggest thing is we tell parents, do you put a heat or cold application on the wound?
Heat.
Remember, this child is bleeding. Your goal is to stop the bleeding or the bruising, so you want to put cold application on a pack of ice really quickly. Because what that does is vasoconstrict. Glad you caught that really quickly. With a little bit of corticosteroid. NSAID. You have to be really careful with NSAID because, like aspirin, we don't give aspirin because it can cause bleeding as well. Okay? So yeah. So the corticosteroids are primarily what's used in these patients. So rice, you've heard of rice, that's what the rest. If they're having excessive bleeding, bruising, we want them to rest. It's not the time that they need to go, play sports, contact sports, especially. Ice, right? Compression, maybe an ACE bandage in the area to kind of support the place, and then elevation. You preferably above the heart. That's what RICE is, acronym. Rest, ice, compression, and elevation, preferably above the heart, if possible. All right, leukemia. I'm going pretty quickly because we have about 3 minutes left. Leukemia. What is the underlying problem with leukemia? Okay, so bone marrow is affected, usually lymphatic system. What is the underlying pathos? Leukemia. What blood cell is affected here? White blood cell. So you have significant proliferation of white blood cells, immature white blood cells. So if I were to get a CBC on this patient, the WBC is going to be significantly high. So it's a proliferation, right? But these WBCs are so immature, they don't really provide any protective mechanism for the body. Okay? So that's one indication, and so when we do see this, that's when we send the child for further tests. Send them for further tests, and most likely a bone marrow aspiration all the time to really find out what's going on. Okay? So you have all of these immature white blood cells that are being produced. The child doesn't really have much protection. What signs and symptoms do we see in the child? Sick all the time, usually a lot of upper respiratory. They've been on a course of antibiotic and maybe even steroid, and then they come back and they're still sick. And they're sick. So frequent infections, frequent upper respiratory ear infections we see in these kids. Maybe sometimes bone pain. They're excessively tired. And parents can't put a finger on it, right? Because it's not very specific. It's just kind of these general signs and symptoms that they feel. So a lot of times when we do see children, and by the time they're diagnosed, a lot of time has passed from this. Because they've seen their PCP or primary care, and they've given them antibiotics, and they come back in 2 weeks, they come back in a month, if things doesn't improve, and so time goes by. Some of the definitions here are what we see as well complications, history and physical, and what really is the bone marrow aspiration that gives us a definitive diagnosis of leukemia. How is leukemia treated? Some of you were on the oncology unit, heme-oncology unit at PCH. Chemotherapeutic drugs, IV chemotherapy. That's at the end. That was your last treatment. But initial treatment is really chemo. Sometimes they add radiation with it. Okay. What was that? So bone marrow transplant is kind of at the end as well. So initially what they'll do is what's called an induction therapy. Try to reduce the amount of white blood cells, get the bone marrow to start working on its own, things like that, right? So that includes chemo, destroying the abnormal cells with chemotherapy, and maybe even radiation. Most cancer treatment today is multimodal, which means 2 or more things are done to help control or alleviate the cancer. So review the prognosis, the effects of chemo in general, right? I don't expect you to know chemotherapeutic drugs, but this kind of gives you an idea of what it does. Most chemotherapeutic drugs attack fast-growing cells. Okay? So if you have these immature WBCs that it's trying to capture, but it's not very targeted to WBCs. So you have other cells that are fast-growing in the body, right? Hair cells, skin cells, GI cells. And guess where you have the most complications with chemo? Very gone, gets irritated, lots of nausea, vomiting, diarrhea because of GI issues. Okay? So read through that in general. I don't expect you to actually, nurses have to be certified in order to get chemotherapy. HIV you can review on your own. And the last thing I want to finish, and I'll let you go, is the blood transfusion. Many of these conditions we've talked about, they're getting either blood or blood products as part of treatment, correct? And as a nurse, RN, you will be required at some point to give a transfusion. So I want you to know what the protocol is, general protocol for transfusion. I don't know if you heard over the end of last year at St. Luke's. Yes, the lawsuit is still going on. A patient was given the wrong blood transfusion because there was some confusion or the protocol wasn't followed. Every time you give blood and blood products, please follow the protocol every time to the T. Make sure you have orders. Make sure you verify the blood when it comes to the unit is 2 RN. And 2 RN sign and document that you verify both. Once you verify, don't let go of the blood product. Does that make sense? What I heard there is she left it on the unit, station somewhere, and somebody else picked it up and gave the wrong. So I just learned. I'm just type-A personality, I tell you. Once we both looked at it, I usually keep it. I don't lose it. And you have to give it within about 15-20 minutes once you get it from the blood bank, right? Because when the temperature starts to change on that blood, it can start to coagulate and destroy the blood cells quickly. Okay? So you want to give it within the time. Make sure the vitals are taken prior to. There are no fever in children prior to giving the blood transfusion. If there is fever and for some reason it's related to, like for example with leukemia, you're going to have fever, make sure there's orders that indicate that the practitioner knows about it. There is communication and the orders are given. A lot of times we give them antipyretics prior to and then give the transfusion. But again, the orders have to be there for your safety, for the patient's safety. Once the transfusion is started, what's the only IV fluid that can run with blood?
Normal saline.
Normal saline. That's the same for adults as well as children. It's normal saline. Most isotonic with the blood. Okay. Less destruction of those RBCs and cellular components. So make sure you have IV fluid. I remember a few years back, my mom was in the hospital for surgery, and she needed blood after surgery. Okay. And so the nurse was there. Her IV that was going was just lactated ringers prior to. This nurse comes in, starts to put the blood, and you know, I never stay away from my mom or dad when they're in the hospital because I just learn. Nurses are great. You get so busy that you forget to do some of the simple things. I said, are you going to leave that IV there? And she looked at it and she said, oh, because I'll be right back. So came back with a normal saline. Okay? So it's very important. Just normal saline with blood. All right? Once the transfusion starts, what do you need to do as a nurse?
Monitor.
Monitor the patient. Make sure somebody is there. The younger the child, I'm sitting literally right next to the child with a chair. Okay? Take vitals. Every 15 minutes, vitals should be taken for the first hour. And what's the big thing that I'm watching? An allergic response. It may be very minor, like the child starts to get, or the child's squirming and churning, that they quite can't verbalize that they're feeling something is going on. So you're watching, so for some irritation, agitation, itching, maybe, they're starting to come up in the areas that you can see. What do you do if they have an allergic response?
Stop the transfusion.
Stop the IV immediately. Don't wait to call the doc. Don't wait to call the response team. Stop the IV immediately. Does that make sense? First thing that you do, and then you call for help. Notify the practitioner, and then you get orders for what you need to do. A lot of times we cut the blood or send it off to the custody. Do a lot of lab work on the patient, a lot of paperwork on the patient. Okay. But within the hour or so, the child is comfortable, etc. You just come back and make sure you take those vitals every 30 minutes or so. Every department or every facility has a protocol, and you got to make sure you follow and document. And we all know if it's not documented, and then don't document something you did not do either. On that note, I will take any questions that you have. If not,